Hi everyone, good evening. Thank you for joining us for the Antenatal Shared Care Infant Feeding Update. My name is Lauren Thomas and I'm CPD Program Officer with Central and Eastern Sydney PHN. I would first like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community and pay respect to elders past, present and emerging. I also extend that respect to Aboriginal and Torres Strait Islander peoples who may be joining us tonight. At the end of the webinar, the evaluation survey will be available from the chat box and also will be sent out to you in an email. We really appreciate your feedback, so please complete this to allow us to issue certificates of attendance. Tonight's event has been RSCGP accredited for 1 hour of educational activity. To qualify for that, obviously, you'll just have to attend the entirety of tonight's session and we will submit those hours for you. So if you'd like to ask a question, please submit that via the Q&A box, which is just at the menu at the bottom. And also, I would just like to draw your attention to some of the upcoming events. So we've got nephrology medical update on Thursday, the 26th of October at Hazelhurst. We have electronic referrals to the SLHD and SES LHD on Monday, the 30th of October. And we have CPR at the Cesspin Mascot office on Monday, the 6th of November. We also have, for antenatal share care GPs, we also have the Royal Hospital Women Obstetrics and Gynecology update, which will be held on Saturday, the 11th of November, both in person and online. So if you'd like to attend, there's a QR code on the screen. Otherwise, I will send out the registration link in the email. And if you'd like to check out any of our events, please check out our website. So now I would like to introduce our speaker for tonight, Dr. Melanie Mapleson, who is a local GP lactation consultant, who's also one of the St. George's and Sutherland Antenatal Share Care GP advisors, who will be presenting tonight on breastfeeding essentials for GPs. Thank you, Melanie.
Thanks, Lauren. I'm just going to share my screen now. Okay. All right. Hello, and welcome to this presentation on breastfeeding essentials for GPs. I'm really delighted to be giving this talk. My name's Mel Mapleson, and this topic is my passion. I love sharing knowledge about breastfeeding because as GPs, we're so perfectly placed to support parents through their breastfeeding season, but often these problems get turfed to lactation consultants or dismissed as normal. And a good analogy, I guess, is just because I personally don't suffer from asthma doesn't mean I'm excused from knowing about asthma. And breastfeeding is the same. Everybody should know the basics. Painters over the centuries certainly have found breastfeeding mums to be a subject of great interest. These are just some of my favourites. So who am I and what did I do to deserve your attention this evening? Well, I'm a GP-LC or a breastfeeding medicine doctor. I no longer work in regular general practice since I chose to narrow my focus by getting my international lactation credentials and POSSUM's accreditation. So I now run a perinatal clinic looking after parents and babies. And I feel like after 18 years since sitting my HSC, I finally found my dream job. It is the best. I'm a solo mum by choice, and that's my little boy there in the photo. So just a note on language. I am really very careful about the words that I use. Not all people who birth a baby or lactate are women. And in fact, not all people with lactating breast tissue identify with having breasts. So tonight I'll default to she, her pronouns, but the take-home message here is always ask, never assume, and be respectful at all times. So why is breastfeeding knowledge so important? Because unless you work in aged care or in a non-clinical role, you're 100% guaranteed to come across patients who are either breastfeeding or breastfed. Our advice could mean the difference between a breastfeeding relationship that continues or that doesn't, and the ramifications of that, both mental and physical, can really be lifelong. So what do GPs really want to know about? I recently conducted a small survey to canvass a group of GPs on precisely this question, and these were the topics that they indicated they'd like to know more about. Wow, I know. If only we had a week-long masterclass. Sadly, we don't, but what we do have time for today are these, which I thought were some of the most helpful practical topics that would help the broadest range of GPs. So here are our learning objectives. In a nutshell: mastitis, pain, medication and imaging safety, and where to find reliable help. So let's hit the ground running with mastitis. There's been a lot of new literature in recent years on mastitis, and a lot of what we thought about the management of mastitis sort of went out the window. We don't have enough time to run through the mastitis, the new physiology theories, but let's appreciate that mastitis is thought to sit on a spectrum of breast inflammation that ranges from white spots through to abscess. And so most of the measures that we use to treat mastitis conservatively are based on the idea that it's an inflammatory condition first and foremost, which can sometimes evolve into a bacterial situation. Most cases of mastitis resolve with conservative care alone. So here's what I do now when someone presents to me with acute mastitis. First of all, a good check-in with mum to see how much support she has and where she's at generally. What's her body allowing her to do right now? What's her mind allowing her to do right now? Making sure that baby is attached and positioned in a way that allows effective milk transfer is really important, because milk stasis caused by an improper latch is one of the most common causes of nipple damage and mastitis, and we'll get to positioning and attachment later on. It really does pay to observe a feed. Feeds need to be frequent and flexible, on demand, especially on the affected side. There is absolutely no role for withholding or reducing or spacing out feeds in acute mastitis. Get onto a regular NSAID early. Remember, inflammation of the breast is the root cause. Panadol, rest, hydration, all really important. External pressure, like from a tight bra, is going to make it worse. So a well-fitted, gently supportive bra is best. A warm pack before feeds and a cool pack after feeds, I find, can help with pain and swelling. And one of the best cool packs I've come across is actually a clean nappy soaked in water and kept in the fridge, and then she can just pop it straight on when she's ready. Lymphatic massage of the breast is ultra delicate. We're talking like caressing the surface of a water balloon without distorting its shape. And the strokes go in the direction of her armpit. It really is best to demonstrate this to people so that they know exactly what to do. And this can be done using, for instance, the surface of your knee. If you don't have a breast demo model or a knitted breast. She might want to consider side-lying feeds if being upright and having pressure on the breast affected is too painful. Make sure you do follow up in 48 hours or so, and don't jump in with antibiotics unless they're indicated, and we'll get to that in a second. The only time I would really give a script to hold on to is, for instance, before a long weekend, or to a mum who has a history of recurrent bouts of mastitis. I do make sure that I type up a quick list of all these things in rough dot points for her to take home, because goodness knows she won't remember anything otherwise. So these have I have less evidence base for, but certainly a body of anecdotal evidence in my patients and the broader perinatal community. And there really is a need for more research into these areas and their impact on both inflammation and the microecology of the breast. So I tend to discuss these as peripheral options to consider, with the caveat that they may not make any difference. They may help, they won't harm you, but for them to not feel bad if they choose not to opt for these. I don't have any attachment, financial or otherwise, to any brands, but I'll give you some examples as a starting point. So EPA predominant fish oil, we've got Bioceuticals who make an ultra clean EPA plus, which is fairly high dose. Vitamin C, I usually recommend quite high dose, up to 2 grams, which I think it's Swiss makes a 1 gram tablet, so you could just pop in 2 of them, which is easier than taking 4 of the 500 milligrams. Lactobacillus fermentum is one of the only probiotics that has been extensively studied in the context of inflammatory breast disease. You may be familiar with the Chiara tablet, which contains L-fermentum, but the other one that does is also LifeSpace breastfeeding probiotic for about half the price of Chiara. Therapeutic ultrasound for acute mastitis is typically done by a trained physiotherapist. I haven't trained in this or seen it done myself, but certainly I've had patients come back who tell me it has helped them. So antibiotics, when to give them. If mum presents already with systemic symptoms, or if she's already tried conservative measures for 24 to 48 hours and hasn't noticed any improvement, then that's when antibiotics are indicated. Keep in mind that if you do decide that antibiotics are indicated, don't forget to also tell mum about all the other things that can help her recovery, which we just covered. What do we give? First line is Fluclox, 500 milligrams 6 hourly, and otherwise Keflex or clindamycin, depending on the severity of the patient's history with penicillins. For all of these drugs, start with a 5-day course. If rapid resolution of symptoms isn't really apparent, then I would continue for 10 to 14 days. And if mum's case is really severe from the get-go or not responding to treatment, then I'd recommend some bloods for a full blood count, CRP, plus or minus LFTs if she's been on Fluclox for more than 2 weeks. A diagnostic ultrasound of the breast to check for abscess, and also breast milk culture by sending off some hand-expressed milk in a urine jar. So what's not helpful? This is a really important slide because some of these things have in the past been front and center of our advice, and they are no longer recommended because in fact they can do more harm than good. We used to tell mums to get in the shower with their electric toothbrush or vibrator and give their breast a good pummeling under the hot water with their palm and their toothbrush to supposedly free the blockage. We now know that this is entirely counterproductive and can worsen inflammation. Definitely no pump and dump. Baby should be feeding frequently on the breast, and if mum is pumping, then the milk is safe to drink through a bottle. Don't reduce feeds, don't wear a tight bra, don't soak the breast. It will really macerate the skin and increases the chances of infection. Dangle feeds can really compromise attachment of baby onto the nipple. Cabbage smells funny and it's not needed. And we need to also remember our role in antimicrobial stewardship. So really throwing antibiotics at every mum with mastitis that walks through the door isn't evidence-based practice. So there we go. There's some resources that I used. Now let's move on to breastfeeding pain and how we can give quick and effective first aid. So we'll start with some myths. Breastfeeding is always painful to begin with. Your latch looks perfect, so just try to push through, toughen up your nipples before baby arrives. Buy this expensive pillow and it will solve all of your problems. It must be tongue tie. You need to unfold the baby's lips. And haven't we all heard all of these before many times, etc., etc. Of course, sometimes you will still need to refer on to a lactation specialist, but there are absolutely a few things you can do in the meantime, which might just prove enough to eliminate mum's pain. And wouldn't that be wonderful? I'll keep these as practical as possible. And just a shout out to Dr. Pam Douglas, whose research on Gestalt breastfeeding really does form the backbone of my work with breastfeeding mums. Okay, so what can we do? If you learn just 4 things about positioning and attachment, make it these. Number 1, get mum in a reclined position. So we're talking lazy afternoon, 45 degrees deck chair position. Make sure she's got some lower back support. I'm blessed with a feeding couch in my room, but if your patient is sitting in a plastic consult room chair, that's okay. Just get her to slide her bottom forward. Don't let a chair deter you from fixing her pain. Number 2, remove all barriers between mum's body and baby's body. The worst offenders are baby's own arms and mum's bra or mum's clothing. So just use your pinky fingers to unhook baby's arms out of the way and get them either side of the breast in a wide embrace and get mum to take off any clothing that's bunching up or in the way. Number 3, tummy to mummy. We really want baby's tummy to be fully in contact with mum's body. You'll often find that baby's body looks like it's falling away or angling away from mum. And what you want to do is use the palm of your hand to gently help mum and her forearms to secure baby in a nice snug hold up against close to mum. In fact, what I would say in these words is, see how baby's tummy is pointing towards the sky and falling away from you. I'd love to see us close that space in between yours and his bodies and really bring his tummy to mummy. All we need to do is gently roll him towards you, just like this, no need to unlatch. Just roll him in towards you slowly. That's what I would say. Number 4, full face plunge. We want full surface contact between baby's face and mum's breast. I sort of imagine it like 2 water balloons pressing up against one another. This helps to ensure that the latch is deep. The less fiddling around we do with baby's lips and mum's breast tissue, the better, and the less drag we have. Again, just use your hand like a paddle with firm pressure behind baby's shoulder blades while they're up against mummy's tummy. Don't put your hand behind their head or neck, just behind baby's shoulder blades to close that space between face and breast. And I'll show you some photos in a second. There are a bunch of ways, different ways that people express this. Number 4, deep face breast berry, 4-point contact of nose to chin, 2 cheeks and chin, face plunge. But my personal favorite that I use with patients is you want to look down and see baby's face smooshed into your breast. So let's eyeball some photos because they're worth 1,000 words, really. Here are some great examples of suboptimal latch and positioning that were causing significant pain to mum. In all 4, you can see huge amounts of space between baby's face and mum's breast. And this is what I would describe as hanging off the nipple rather than smushed. Second from the right, you can see there's a little hand sitting between mum's and baby's bodies that needs to be gently moved away so that baby can get in closer. And in the 2 photos left of center, you can clearly see that baby's tummy is nowhere near making contact with mum. So a gentle roll in towards mum could make a huge difference there, and you can easily do that with your hand. Comparatively, these are what I would call smushed babies. Would you agree? So you can see in that photo on the left how beautifully this baby's tummy is right up against mum, giving him lots of positional stability. His hands are out of the way and his face is making contact from nose to chin. Likewise, in the other photos, it looks like baby's comfortably feeding with a deep latch and stable position, making the chances of pain for this mum or these mums much lower. This is what you're aiming for, and you can help mum achieve this with some gentle hands-on guidance. I'll just go back to this page for 1 second so you can see the difference. And then that one. Okay. All right. So as much as I'd love to talk more about pain, and I could talk about it all day, without further ado, let's shift gears and talk medication safety in breastfeeding. The reason this is important is because there's a lot of this advice going on, both in hospital and GP rooms, and it has to stop. You'll leave here tonight with enough resources to never have to second guess yourself again or indiscriminately tell women to pump and dump their milk. That is a bold claim, but it is true. I'm confident that you will leave feeling equipped. Okay. The benefits of breastfeeding outweigh the risk of exposure to most therapeutic agents via human milk. Absolutely. The vast, vast majority. Now, this is just a small selection of the hundreds of calls for help on Facebook, on a bunch of our local mums pages. Because if parents feel uneasy about advice they've been given, who do they turn to? Facebook, of course. And sadly, a large proportion of these posts are from distressed mums who were told to stop breastfeeding by their GP because of medication, when in fact the medication would have been very safe to take while breastfeeding. So we need to do better. Okay, so basic principles. Pump and dump is a thing of the past. There's no excuse now. There are resources available for us to check medication safety, and the resources are free or very low cost. I always check. My brain is not a computer, and I prefer actually to tell parents word for word. I like to view the safety information every single time to be sure that we're making the safest, most up-to-date decision for you and your little one. And they are always happy for me to double check. Pump and save is certainly preferable to pump and dump when it comes to radio traces that stick around in the milk for a while, to allow their radioactivity to dissipate before feeding the milk to baby, and we will get to that. In rare circumstances, an appropriate alternative medication is usually available, or cessation of breastfeeding might be needed with ample support and counselling, but this is rare. So you're probably sitting there thinking, Mel, just tell me what they can and can't have. And my answer to that is there is no single page quick notes on this. Part of being a breastfeeding advocate is looking up breastfeeding safety data for medications when you prescribe them, because relying on medical director or best practice or other record software to tell you what's safe isn't really good enough. You don't have to hold it all in your head, though. I'm going to give you a handful of reliable evidence-based resources and tell you also which ones are my favorites to use. So this is just a short representative list of things that are contraindicated in breastfeeding that we know of, and some that need close monitoring. So codeine, there is a low risk of rapid metabolism, generally best avoided when mum is breastfeeding, and there are certainly suitable alternatives for pain management. Chemo, these drugs are generally poorly studied in breast milk, but suffice to say they can transfer to baby, and anti-neoplastic agents are not safe for babies. I myself had to wean my toddler the week before I started chemo earlier this year. There was really no other option, and although this is one of the rare instances where if the mum of a newborn, not so much a toddler, a newborn was hoping to continue breastfeeding and needed a short course of chemo, then she could consider pumping and dumping through her chemo season to maintain supply until her milk was safe enough to give again to her baby. Roaccutane is highly lipophilic and concentrates in breast milk, so it's not recommended. Lithium, valproate, amiodarone, all examples of medications that with appropriate pediatric support and close monitoring should be able to be continued in a breastfeeding mum. We'll get to the resources shortly. Anesthetic safety, I won't spend too much time on this because the take-home message is quite simple and has been repeatedly confirmed in reputable literature in recent years. The general principle is that a mother can resume breastfeeding once they become awake and alert after anesthesia has been given. Resumption of normal mentation is a hallmark that medications have redistributed from the plasma compartment and thus generally the milk compartment. So a lot of practitioners still default to the pump and dump for 24 hours after anesthetic advice, which is really outdated. This is relevant for us as GPs because patients will ask us these questions. I had an exclusively breastfeeding mum 3 weeks postpartum come in very distressed because she'd been told by a surgeon's receptionist that she would have to pump and dump for 24 hours after anesthetic for her episiotomy review. I advised her that the evidence would suggest this is not the case and that she should be able to continue breastfeeding uninterrupted once she's alert, and to discuss that with the treating surgeon. Codeine and pethidine are generally best avoided perinatally, and hydromorphone just needs to be used with caution at high doses, but still can be used. For our really vulnerable infants like preemies or those at higher risk of apnea, pumping and saving, not pumping and dumping, the breast milk for 6 to 12 hours following a maternal anesthesia would generally be considered wise, and that milk can then be given to baby either when they're a bit older or diluted with drug-free breast milk and given to baby as needed. Okay. So imaging safety. When we send patients off to get their contrast CT or mammogram or bone scan, etc., let's make sure we keep interruptions to breastfeeding at a minimum. Telling an exclusively breastfeeding mum that she has to pump and dump for 12 hours after a scan when she perhaps has never ever used a pump and baby has never seen a bottle is next level stressful and rarely necessary and can seriously jeopardize a breastfeeding relationship. So this diagram's taken directly from the Academy of Breastfeeding Medicine's clinical protocol number 31. Titled Radiology and Nuclear Medicine Studies in Lactating Women. This is the most concise, user-friendly, evidence-based summary I've come across, and I certainly use it as a key resource in my daily practice. It looks awfully chaotic, but fear not, I'm going to make it crystal clear for you. So green light means go forth and breastfeed after these, no interruption required. You'll notice this includes non-contrast scans, X-ray, contrast CT, contrast MRI, mammogram. The darker green window in the center there, I made around the low-dose technetium-99 tracer scans. It's there to let you know that the International Atomic Energy Administration guidelines for that particular tracer are a little bit more conservative, and they recommend withholding breastfeeding for just 4 hours after these scans. Which really, if timed cleverly and mum feeds just before the injection is given, then it really means minimal interruption to most mother-baby pairs, because they can feed just before and then at the next feed 4 hours later. So all of these are perfectly safe for no interruption to breastfeeding, except perhaps just skipping one breastfeed or a period of 4 hours. Small selection of thyroid and cardiac imaging scans do require some time to pass to reduce radioactivity of the breast milk. Really discussing this with the nuclear medicine physician about what time frame mum is required to pump and save is important, and how long the milk needs to be stored for in order for it to be safe again for baby consumption. It usually depends on the dose and on the half-life of that particular tracer. You'll notice I've included PET scan in the orange flag page, even though the diagram says no interruption. That's right, insofar as no interruption to breast milk for baby is required. PET scans typically use a tracer called FDG, which is not excreted into breast milk, so the breast milk is perfectly safe. However, FDG levels in breast tissue after administration are quite high, and therefore close contact with the breast, such as during breastfeeding, could expose the infant to relatively high doses of radioactivity. Based on the half-life of FDG, it's recommended that mum limit close contact with baby for 9 hours after the injection for the PET scan. And during that time, she can and should express milk to be given to the baby by another carer without any delay. There doesn't need to be any storage of that milk to dissipate radioactivity. It can be given straight away. The issue here is actually contact with the breast tissue. At about 9 hours, 98.5% of the radioisotope would be decayed away, and therefore basically back to almost background levels. And so it would be safe for mum to resume normal contact and direct feeding with baby 9 hours after that FDG injection for the PET scan. But meanwhile, baby will have had the expressed milk without any issue. The use of radioactive iodine-131, like for thyroid imaging or the treatment of thyroid cancer or Graves' disease, does require complete cessation of breastfeeding. In fact, it's recommended that a breastfed baby be weaned at least 4 weeks before mum receives the therapeutic dose of iodine-131 to reduce the radiation dose to the breast, because the density actually changes, and the risk of contaminating clothing with leakage of radioactive milk. If mum is still lactating actively and leaking onto her clothing, then her clothing also becomes radioactive. So they do recommend weaning with a period of time beforehand, and baby cannot have any more of that milk for a long period of time. So here you go, our most commonly ordered imaging tests and their breastfeeding traffic light labels. There's no excuse now to give indiscriminate pump and dump advice to any mum needing imaging done. You can come and check this. You take a photo of it if you want. The diagram is easily available, and I've put the link in the resources as well. I added the colors, so if you want to take a photo of that for reference later, please do. Okay. So we're moving on now to the final part of my talk tonight, and hopefully we'll have some time at the end for questions. And this part is about where you can find help when you need it and if you need it. The list of resources might seem overwhelming. You'd be forgiven for feeling that way, but what I recommend that you do is listen to me outline each one and have your phone at the ready to take a photo of the ones that you think suit your style. And then at the end, I will also tell you which ones of these are my most used and my favorites, so that you can opt for those if you prefer. But I enjoy giving people as much information as possible on these resources, because different resources suit different people. So unless you want to spend hours combing the internet to find these resources yourself, or you want to just throw your hands up and say it's all too hard, go and see the LC, then I recommend you stay here and don't take a toilet break right now. Okay, so we'll start with some apps. Infant Risk for Healthcare Professionals, or Infant Risk HCP, is a really user-friendly app that uses a risk rating scale to guide decision-making for medications and over-the-counter treatments. It's built on the same evidence base as the works of Dr. Thomas Hale, who is really a global leader in medication safety for breastfeeding. The app costs about $15 Australian a year for full access on your phone. It's kept up to date. It's very evidence-based, and I really like it. Next app is Mummy Meds, which is the parent-friendly version of the Infant Risk app, and it's built on the same medication safety data, but presented in a way that's simpler because it's patient-facing. It costs about half compared to Infant Risk, but I find the information on there to be equally as helpful, and unless you want to go into great depths, this is probably sufficient for what you need. Lactrix. The Lactrix app is based on the renowned LactMed database, which some of you might already use, and it's very, very comprehensive for anyone wanting a lot of literature detail on medication safety in breastfeeding, but I find it a bit less practical for everyday use because it lacks a risk rating. It just gives you a lot of information. However, it is totally free to download, and it doesn't require you to set up an account, so those are definitely advantages. Moving on to desktop websites, LactMed is the official database on which the Lactrix app is based. It's really in-depth, it's evidence-based and up-to-date, but similarly to the app, I personally find some of it a bit too wordy for a quick glance. It's free to access, and it is a good one to have bookmarked. PBMG, the Pregnancy and Breastfeeding Medicines Guide, is an online resource developed by the Royal Women's Hospital down in Victoria, and it is a fabulous resource in my opinion. The layout is super clear, the information is helpful, it gives concise recommendations on whether a medication is safe to use or not, and personally I think the $170 per year price tag is totally worth it for this Australian resource. eLactancia is another online medication database developed in Spain, but with a fully translated and up-to-date English version. And the reason I love it is it's so clear in its recommendations for breastfeeding with a color-based risk rating. And the other thing it does is it also makes recommendations for safer drug alternatives if you've searched something that is a higher risk drug. It's entirely free, no account needed. You can access it straight away. Trash the Pump and Dump is a fairly self-explanatory website name, but rather than being a breastfeeding, a medication database, it's more of a collection of articles on safety for breastfeeding. So for instance, you'll find an article on anti-seizure medications where they address common medications in more of an essay format. They also have a section on imaging safety. I think this site is great for self-directed learning or bumping up your CPD points if you want to do some reading, but not my first choice for rapid access to check a drug during a consult. So the Breastfeeding Medicine Network Australia and New Zealand is a fantastic resource, which is actually relatively new. And what it does is it allows you to search for doctors with expertise in breastfeeding medicine. It lists their location and their contact details, and also it tells you whether they perform tongue tie release. This is wonderful if you have a patient who you'd like to refer on for complex management and you want to see if there's a practitioner local to you. And they also hold conferences and online learning opportunities fairly regularly. And if you'd like to join the database of the Breastfeeding Medicine Network Australia New Zealand, there's also the option to do that if you're an existing doctor who practices in lactation medicine. LCANS, or Lactation Consultants Australia New Zealand, is your go-to to find a registered lactation consultant near you if you need one. Dr. Pam Douglas is a Queensland-based GP IBCLC. She's the champion of neuroprotective developmental care research and Gestalt breastfeeding method, and she's authored a vast pool of publications on breastfeeding and lactation, which I thoroughly recommend reading if you have the interest and the time. Okay, so a bit of a sideways shift into phone numbers because, you know, yes, sometimes even myself as a millennial should just pick up the phone and make a call. I'm sure most of you are familiar with Mother Safe. It's a New South Wales-based free helpline that welcomes calls from both health professionals and parents to answer questions about safety in pregnancy and breastfeeding. It's free, and there are the numbers down the bottom there for you to save. Okay, Rodney White. This gentleman is very popular with parents, I should say. He's a Victoria-based pharmacist with a lot of experience and expertise in medication safety for breastfeeding. He takes calls from practitioners and from the community, and from what I hear, he's an absolutely lovely chap and very, very knowledgeable when giving advice on drugs. His contact details are also there for you to save, and I may have to apologise to him if he gets a big influx of calls next week. Also free is the Australian Breastfeeding Association helpline, which is staffed by volunteer breastfeeding counsellors who won't advise you on medication safety, but they can give you guidance on breastfeeding matters like breast refusal or supply concerns. And what you can do is you can also encourage patients to call the helpline themselves. So from phones to Facebook, here are some groups that you might be interested in joining if lactation is one of your special interests. And personally, I've learned so much from these pages, and there's nothing like having tens of thousands of global colleagues at your fingertips if you have a particularly unusual breastfeeding conundrum. So there's doctors practicing breastfeeding medicine or want to, a very specific name there. Medical mums and mums-to-be, which generally includes dads as well, lactation interest, and Dr. Milk. This is the hard copy Hales Medications textbook on which the Infant Risk app and Mummy Meds app is based. I don't imagine many people nowadays would purchase a textbook, but here it is in case you're one of those people who really loves the smell of a new book. So by now you're probably sitting there thinking, oh my goodness, just tell me what to use. This is way too much. Point taken. But I do hope the breadth of resources that I've given you here gives every single person the opportunity to find a style of resource that suits them and the confidence to know where to get help. Take what you like and leave the rest. But you don't need to go and get a diploma of breastfeeding to make safe choices and to be a breastfeeding advocate. My personal favorites are these ones. So if I were unsure about a medication during breastfeeding, I'd typically look it up on Infant Risk on my phone and then cross-check it on PBMG, the Victoria-based database online. I don't often need to call, but if I were still on the fence, I would give Mother Safe a buzz. Imaging safety, I refer to the table in the ABM protocol number 31, the one that I annotated with colors. And sometimes I drop in on the Trash the Pump and Dump website section on radiology for some extra reading. If I need to refer on, either because I'm on leave or because a patient is out of area, I go straight to the Breastfeeding Medicine Network website or LCANS. The breastfeeding method that I coach and that I like to stay up to date with is called Gestalt breastfeeding, which was founded by Dr. Pam Douglas, and a lot of her published works and literature are freely and widely available online. So these are my most used, my favorites. I do have all the resources bookmarked or downloaded on my phone, but I certainly wouldn't expect every doctor to do that. That's just not necessary. So here are the links to the resources that I've just covered. And here just touching on how really breasts and breastfeeding are still shock horror in 2023, so publicly controversial. In fact, I just read recently a case of a woman breastfeeding with a cloth cover in a very expensive restaurant local to me, who was asked by staff to move away from her table during dinner purely because she was feeding her baby in the view of other patrons, which, by the way, is entirely illegal to request someone to move for that reason. So I'd like to say a special thanks to CESPN for allowing me this opportunity, to my patients, to my wonderful practice team at KFMP, and to my greatest teacher of all, my 3-year-old son, Mitch. This is how you can find me. I do really love connecting with other doctors who are interested in breastfeeding medicine. I'm open to coming to other practices to teach breastfeeding skills. And I'm really hoping that this talk has helped you, because for every one of you that has learned something, even just one thing tonight, hundreds of parents and babies will be helped downstream. So thank you so much and have a great week. And I feel like I've spoken really, really fast, because when I ran through this earlier, it took the whole hour. So I think we've got some time for questions, which is great. So yeah, I hope that was helpful.
Hi, Melanie. It's Lauren. Thank you again so much for that presentation. I think that was great. We do have a few questions, so we'll get stuck into it. We do have some time. So one of our first questions is, what SSRIs can they take, as some need them for postnatal depression, and this is a common problem. Also, any antibiotics you can't use.
So SSRIs, generally, I would say if a woman has been already on an antidepressant through their pregnancy, I would absolutely keep going with that. No need to stop. If you're wanting to stop a new SSRI in the postnatal period, then our usual go-tos like sertraline, escitalopram are very safe options. In fact, you'll find if you look up on infant risk, both of those options are very safe, and the risk of having postnatal depression or anxiety untreated far outweighs any small risk of minute transfer of those drugs into breast milk. So there, I would say go with the top ones that you would normally prescribe for a woman who wasn't breastfeeding, who presented to you with depression or anxiety. I always double check it anyway, but my first line would be sertraline, perfectly safe. Sorry, what was the other question?
It was asking about any antibiotics you can't use.
Oh, right. So if we're talking main antibiotics that you would be needing to use, for instance, for mastitis or as a common infection, either respiratory or skin, let's say, or even gastrointestinal like Flagyl, all of those are perfectly safe to take when breastfeeding. I would say on a case-by-case basis, I would run the medication through a check anyway. But off the top of my head, I can't think of any that would be absolutely contraindicated that would be commonly used in a breastfeeding mum. So, all of the main antibiotics that I would use in common infectious presentations are totally fine to use if breastfeeding.
Okay, great. Thank you.
I know that I think it's Fluclox pops up as a warning. If you have mum recorded as breastfeeding on medical director or best practice, it pops up as a warning to not prescribe because mum is breastfeeding, which is absolute garbage. It's perfectly safe for baby, and we don't want untreated bacterial mastitis.
Thank you. So we have a few more questions that have come through. So one question is, what about the Nursing Mothers Association phone advice? Do you know if that's still going or not?
So I think I'm happy to be corrected, but I think that has become the Australian Breastfeeding Association helpline. Yeah, because Nursing Mothers was just a bit gender exclusive, and it's morphed into the Australian Breastfeeding Association helpline.
Okay, great. Thank you. The next question we have is, could you tell us about tongue tie that you mentioned? Is it true that if the child can put their tongue at level of lower teeth, is it okay? And when is it a problem and how do we treat?
Okay, so tongue tie is a big topic, but what I'll say is what matters with tongue tie is function, not appearance. Appearance is important when function is impaired, but if the baby is feeding well and effectively and thriving, and mum is not in pain when feeding, but baby looks like they've got a very anterior classic tongue tie and their tongue looks heart-shaped and it looks very anchored to the bottom of the mouth, it doesn't matter what it looks like if functionally feeding is going okay. We don't need to worry about downstream speech or dentition or other issues, because generally it doesn't cause a problem at all, and that's backed up by the Dentists Association statement. But if there is a functional issue, so either baby is not thriving, they're not able to maintain latch, or mum is in a lot of pain, and we think that in fact the tongue tie might be affecting the attachment, then that's where appearance becomes really important. And look, posterior tongue ties are very controversial, and you'll find, depending on who you talk to, they do or don't need to be snipped. But a baby who is having trouble with breastfeeding and mum's in a lot of pain and baby has a clear classic anterior tie where the tip of the tongue is essentially anchored onto the lower alveolar ridge or gum, then those are the ones that absolutely should be considered for a snip. I think that's the question.
Thank you. Someone else has asked, what do you do for breast refusal?
Right, so breast refusal is really, really common. Very, very common. The most important things to consider, I would say, are, first of all, we need to maintain supply. So if baby is not coming onto the breast at all, we need to keep transferring milk from mum to maintain her supply. So whether that's through hand expression or pumping, mum still needs to be draining the breasts in order to maintain supply through the refusal period. The second thing is we need to rekindle the breastfeeding relationship. So what's really important there is that we allow baby to guide their coming back to the breast. Any pressure or forcefulness that we display, I guess, is going to compromise how quickly baby will come back onto the breast. So offering frequent opportunities for baby to be near and around topless mum with no pressure to actually latch on, and certainly no pressure behind the head or neck to attach. Just, I normally tell mum, look, consider the next couple of weeks a breastfeeding vacation or a topless vacation, and just be around baby as much as you can with the breasts available, and allow baby to come on and around the breast and latch on if they want to. But as soon as we start introducing pressure, same with solids, that's when baby gets wound up and dialed up and wants to refuse for longer. So 2 things: rekindle the breastfeeding relationship in a pressure-free way and maintain supply by continuing to drain the breasts. If it's not baby's mouth that's doing it, we need to do it in another way. Usually breast refusal, if it's due to something like a tooth coming through or a tongue tie having been snipped and they've got oral aversion, or baby's just behaviorally having a big leap and their behavior is disrupted, breast refusal I normally see last for a week and no longer. That's pretty common. And then from one day to the next, or from one feed to the next, so long as there's no pressure there, baby just tends to come back to the breast and everything goes back to normal.
Great, thank you. The questions are coming through thick and fast now. So the next question we have is, can GPs use an oral typhoid vaccine for the breastfeeding mum?
Oh, that's a really good question. Off the top of my head, I don't actually know the answer to that. I would have to look that up, and I can get back to you on that one.
Okay, great. Yep. So we can.
The answer would be, I imagine it would be yes, but I will look that one up.
Okay, great. Awesome. Yep. So any questions we don't get to as well tonight, Dr. Mapleson has kindly offered for me to send them to her, and she'll write them up for us, and I will send them out via email at a later date. Okay, that's fine. So the next question is, patient has, now I apologize if I mispronounce this, had hyperprolactemia post-level, I don't know if that's post-level postnatal 850. Can the patient use motilium to induce breastfeeding?
Oh, wow. Okay, that's really specific. I might leave that one till I'll answer that one in writing, because I'm not sure if that will be sort of ultra applicable to most people logging in. So maybe we'll cover the more generic ones and I'll answer that one in writing.
Yep, no, that's fine. That's perfect. So how long can GPs use motilium, and what is the maximum dose?
Okay, so motilium can be really helpful. Thankfully, we can actually prescribe it legally in this country. It's not legal in some other countries, but we can prescribe it off label here in Australia, and it can be really helpful in cases of low supply. Now, in terms of the time period of prescription, the evidence suggests that beyond a course of 4 weeks, there is no additional benefit to continuing motilium after 4 weeks. The dose, what I generally recommend is to start with 1 tablet 3 times a day. So 1 tablet being 10 milligrams, 3 times a day. And then after a few days, if mum is not noticing a significant improvement in her supply and she doesn't really feel the breasts filling up or a difference in her pumping volumes, then you can double that to 2 tablets 3 times a day. And I would continue that for 4 weeks. And I explained to mum that the standard course is 4 weeks, after which we would start to taper off the dose. I wouldn't recommend stopping it cold turkey, because some mums do complain of and present with a noticeable drop in their supply if they do that. So I generally recommend tapering it off over the course of perhaps another 2 to 3 weeks, but certainly continuing on 2 tablets 3 times a day indefinitely for the whole breastfeeding journey. There is no evidence to suggest that that is beneficial. Yeah.
Great, thank you. So another question we have is, what sort of things do you think about with burning pain in nipple with breastfeeding?
So the absolute first thing I would think about and that I would want to do is observe a breastfeed, because the most common cause of nipple pain in a breastfeeding mum is suboptimal latch attachment and position. And it can be so easily fixed with the right guidance. And we can save ourselves from, over-treating thrush, etc., and a lot of other things that are overdiagnosed, I'll say. But burning pain in the nipple, I would absolutely check attachment and make sure we've got effective and painless latch of baby's mouth onto mum's breast. Really, we want to have a good look at the nipple and see whether, what kinds of micro trauma or traumatic lesions there are on the surface of the nipple, whether there might be a secondary infection. Thrush of the nipple and breast is really quite uncommon. But if mum had classic sort of white plaquey dermatitis around both nipples, and the nipples were really inflamed, and baby had, concurrent thrush in their mouth, then I might consider treating for thrush. But really, I would say, in my experience, dealing with, a lot of people who come to me as a last resort, 9 out of 10 cases of severe breastfeeding pain are due to positioning and attachment.
Okay, great. And I think that following on from that, there was a question about the management of a white spot on the nipple.
Yep. So I mentioned before that mastitis sits on a spectrum of inflammation, and down the bottom end of that spectrum, you have sort of your white spots and blebs, which they think form a part of that spectrum of inflammation, albeit a very early stage. There are 2 main types of white spots. in very simple terms, I would say there are those that are very, very white with a clearly defined border, and those are the ones that are more amenable to being lanced. I only do that very infrequently when I do think there is actually a film to be lanced, and those ones have very clear defined borders and they're quite pearly white. The other type of white spot that I typically see is the more hazy border, and it looks almost like someone has painted it on and it's not quite so white. Those ones will not do well if you stick a needle into the top of them. And I generally find, because the underlying cause is generally inflammatory, that if you put a bit of a steroid ointment over the top once or twice a day with a occlusive dressing for about 4 or 5 days, that type of white spot will also will generally resolve. So 2 types: the ones I would lance, and the ones that I would treat with a topical steroid. And yeah, I'd just be very mindful of not lancing the ones that look hazy, because nothing's going to come out and you're just going to cause more trauma. Yeah.
Great, thank you.
Oh, and
Yeah.
I'll just add there, if there's a white spot and it's not painful and it's not bothering mum and it's not bothering baby, leave it alone.
Great, thank you. There was another question about cracked nipples, areola. In addition to checking latch and position, is there any other advice for recovery?
Yeah, so sometimes I see some nipples that are half fallen off, and mum is in so much pain that we can't even do a breastfeeding observation because it's so painful to get baby on that it's just intolerable. So in those cases, I generally recommend something like a topical kenacomb to actually treat the very bad inflammation and just give some coverage in case there are some organisms there, and also a breastfeeding break, so to speak. So on the nipple that is very badly traumatized, I would say pump when baby feeds or when baby's meant to feed. Put the pump on, make sure the pump is properly fitted, and pump your milk for 24 to 48 hours to allow that nipple to heal, so that it can get to a point of at least early healing, so that we can latch baby back on. And I would certainly demonstrate and practice with mum proper fit and hold, or positioning and attachment with a doll, so that she knows when baby comes back on, here's the different position we're going to get into. Otherwise, she'll just re-traumatize straight away if we don't change how baby's coming on. But certainly sometimes if a nipple is very, very badly cracked and mum can't tolerate baby coming on at all, then we need to give that breast a break and pop the pump on for a very short period of time, which is usually 1 to 2 days, to get early healing to occur.
Okay, great. I think we have a follow-up question from the tongue tie, and it is, who does the snip for the tongue tie, and is it safe?
So there's a variety of people who can do snips for tongue ties. There are GP IBCLCs in Sydney who are trained to do that, and the best place to find them is on the Breastfeeding Medicine Network database. There are also pediatric surgeons who will do it, and there are also dentists who will do it. The techniques that they use are all different. People's methods of doing it are different, and also the devices they use. So most medical practitioners will use scissors, but dentists nowadays, a lot of them use laser technique. So yeah, those are the main providers that would do a tongue tie release. Yeah. My concern with the providers of tongue tie release is sometimes some of the providers that do these you can assume that if a patient presents with a concern about tongue tie, that no matter what, they will come out having had a tongue tie done. I prefer providers where at least I hear occasionally some people are turned away because the practitioner thinks it's not necessary to do the snip. Otherwise, I feel like their pre-assessment may not be entirely thorough, because if everyone who goes there gets snipped, I just don't think that's realistic, and there should be a screening process first. And certainly not all parents who think their baby needs a tongue tie released actually do need a tongue tie released.
Great, awesome. I think we are coming up to time, so we might just go with one more question, and then I'll send through the other questions, and I can send them out to the GPs after. So it's any comment on breastfeeding schedules, example, who recommends on-demand feeding until 2 years old versus some guidelines report 3 to 4 breastfeeds a day at 12 months and continuing frequent night feeds versus weaning them.
Okay. So in a nutshell, first of all, we talk about extended and prolonged breastfeeding. So WHO does recommend ideally at least 6 to 12 months of, well, 6 months of exclusive breastfeeding, 12 months of breastfeeding plus the addition of solids. And then beyond that, there are certainly added benefits to breastfeeding up to 2 and beyond if that's mum's choice and preference. Do babies need to be weaned? No, unless mum wants to. Is there a medical reason to wean a baby unless it's, mum starting chemo or another medication that's unsafe? Absolutely not. In terms of frequency of feeding, I very much follow the POSSUMS and neuroprotective developmental care approach, which is babies should be fed responsively, also known as on demand. So whether that be newborn infancy, a 6-month-old, a 12-month-old, it really doesn't matter how you feed your baby, but the basic principles are frequent and flexible. Frequent meaning as often as you can, bring baby onto the breast. It's one of the best ways we have to dial down a baby who's agitated. It's not just about nutrition. And flexible meaning not spaced. So flexible being you just fed 20 minutes ago, baby looks like they're hungry again. The community nurse told me I can't feed until 3 hours. What do I do? Absolutely not. Pop the baby back on. It is not a problem. You can feed your baby responsively on demand. Whenever baby wants to come onto the breast is okay, whether it be day or night. The reasons for night weaning, again, personal preference. That would be really the only reason I would consider night weaning, or mum's going to be absent because she's going back to shift work or something. But is there a medical reason to night wean? No. Is baby going to sleep better if you night wean? No.
Okay, great. Well, thank you so much. And this isn't a question, but it's a comment from one of the GPs that said how fantastic the talk was, and that they hope you put some podcasts up on breastfeeding on breastfeeding sites.
Oh, that's very nice. Thank you.
So we might just.
I'm more than happy to receive emails. I'm off work at the moment. I will be back at work next year, but I'm still very much active on email and social media. So please do get in touch. And I love talking to other people who are interested in this.
Again, Dr. Mapleson, thank you again so much for your presentation. It seems like the GPs have taken a lot out of it, so thank you very much.